Good morning, everybody. Thank you so much. Jonathon Feit here with Beyond Lucid Technologies and the brain trust of fire and EMS technologists. Clint, thank you for the introduction. I'm going to go about 5 degrees to the side of what you said there, because what I'm going to try to do today is talk less about sort of the structure, I suppose, of ET3. We'll talk a little bit about that, but there are folks like Rob Lawrence and others on this call here who can tell you everything and more that you want to know about it. What I'm going to tell you, because I think I have, from what I understand, a bit of a reputation as a data geek. A couple people have called me that of late. I'll take it. Is to talk about the why, and ask the question of the group as to whether the structure of this program, as put forth in this first phase, I suppose, and I think to build on the previous question that was asked before we started recording, I hope it'll come up in the discussion, was what happens to all the rest, right? So not just the folks who got selected for this first phase, but in the broader context of ET3 and what it means for the future of the industry, is are we capturing enough data to be able to support and justify the work, to demonstrate success, and so on. So that's really what I hope we're going to get into here. It looks like, by the way, we've got 34 folks on the call, so this is one of the higher attended meetings we've had so far. So Tony, I think great point, and Clint, to your point about just bringing together an educational topic for people to talk about, looks like people gravitated, and that's pretty exciting. So that said, the topic of my discussion today, the title is the CHIMERA. Apparently, as Tony said earlier, I'm introducing, I guess, the words of the week. A couple weeks ago, it was archipelago, little chains of islands that have links between them. So today we're going to talk about the CHIMERA. And my wife said I needed to make sure I defined that, so we'll get into that. Subtitle here, Hard Questions about ET3 and the Value-Based Care Equation. So as is traditional in our business, with respect to educational discussions, I want to put out some disclosures. Again, I do have a company affiliation with the Beyond Lucid Technologies, but I am not going to be talking about that at all today, other than right now. However, I'm representing here a consulting function whereby there is no product or service per se affiliation, but I do want to throw in a plug for a podcast with GEMS that I host called Sacred Cows and Data Cubes. And in fact, that's where we're going to begin. My mission, which I've chosen to accept, is essentially to talk about I'm going to move this floating thing keeps driving me a little crazy here. So I'm going to stop trying to look at myself, and hopefully if there's anyone sees that there's someone waiting to be admitted, please do let me know. So when I talk about slaying sacred cows, someone who some of you may know, named Bruce Baxter, who's from New Britain EMS in Connecticut, talked to me once upon a time about a book called Sacred Cows Make the Best Hamburger. And essentially, it really came down to this idea that the assumptions that are made in any industry are really the starting points for innovation, right? If you can step away from that which you've held on to just because it's always been done that way, you can really start to move the ball forward. And I think everybody on this call, and even who's not here, can admit that our industry has some sacred cows. So we're going to start with trying to obviate those, basically look past what has always been held as an assumption and see if we can't move the ball forward. So the goals for today, my mission for today, are first and foremost to highlight the fact that I believe that ET3 and whether it's called ET3 or not, and the same thing with community paramedicine or mobile integrated health or mobile integrated paramedicine or whatever we want to call it, could at last earn mobile medicine the seat at the table, right? This is what we as an industry have been trying to get for a very long time. There are people who've been working on that for longer than I've been in this business. The question is, do we deserve it? And that's not as a matter of practice. It's a matter of, can we prove what we do? Right? Can we demonstrate that if ET3, which is coming through CMS at a federal level, is basically saying do value-based care, then can we demonstrate that we in fact do value-based care? So that's one big topic. The second is, again, because I believe that this is a good thing for our industry, can we help agencies justify the investment in this evolved scope of practice or this evolved aspect of practice. I say scope of practice, I think there's some legal weight to that. But in terms of the way of doing what we've always done, if you're going to invest in new ways of learning and new technology and new ways of accounting for what you do, I think it's a good thing. So I want to make sure that we're helping people justify that work. And the final, and this again harkens back to the podcast, because there is a list of questions you will see referenced at the end here that I hope can arm you with knowledge and questions that you will be able to ask of your ET3 programs. And even if you don't have an official one, but like some people who are on this call now, that you are looking at building your own, right? Sort of creating a regional ET3-like program, you still need to ask the hard questions and make sure that you are covering the bases legally and clinically that you need to. So that said, the chimera. In Greek mythology, a chimera basically looks kind of like that. So it's got three body parts. It's kind of slammed together. There's a lion's head, a goat's body, and a dragon's tail. If any of you studies the Old Testament Bible, actually New Testament too, but certainly Old Testament Bible, there's a similar version of that in the book of Daniel. There's kind of one in the book of Revelation. So this image of kind of a malformed, multi-headed beast that has multiple parts is a pretty common image through mythology. And I would argue that we have one in our industry that just kind of showed up. So the ET3 CHIMERA, a beast of a program that really does multiple things, not really any of them very well. And I think from when I step outside of myself and look at why CMS created the program the way they did, it was really the goal to sort of accomplish multiple objectives at the same time. And unfortunately, they just don't really work. One is to create a value-based payment model, so to move from payment by the mile. The second is to essentially create a national framework for something kind of like community paramedicine. There's a whole lot of overlap between CP and ET3. And the third is to recognize that telemedicine is real, especially during COVID, and to essentially, again, create kind of a national framework for utilizing it, but not really considering all of the factors that go into mobile medicine, such as the fact that you will sometimes be moving and go through dead zones, or be in a rural environment and not have a good network connection. And so a lot of those haven't been taken into account. That's a very big problem that's ultimately going to rear its ugly head. So with that said, before the world ended, so this back in March 2020, I gave a presentation at the South Carolina EMS Symposium, the first slide of which said as follows: how does our industry, this was before, actually only a couple weeks before Anthony started the Congress of Mobile Medical Professionals. So I was still using the phrase pre-hospital care instead of mobile medicine. My apologies to the group. This would no longer say pre-hospital care. But how does mobile medicine measure health? Which is to say that we don't, right? Are we looking, we count stuff in our industry, right? We look at shoot times. We look at Narcan administrations. We look at the number of times that we've gone out to visit somebody. We look at whether they've readmitted or not. But how often does our industry ask why? And are they getting better? Does the fact that they readmitted mean that they're worse? Does it mean that they're better? Does it mean that they're now calling for help instead of not calling for help, for example? And we'll talk about that a little bit later, but the most cost-effective patient that you will find, aside from a dead one, is one that doesn't call for help, right? They take care of themselves at home. They sit at home. They sort of wallow in their own illness. They never utilize the resources. So when we look at things like cost reduction, is that the appropriate barometer in order to see what it is that our industry does? And are we engaging in delivery of value to the healthcare system? But if we don't measure it, are we doing it? And so here again, how do we measure health? This is going to be my motif today. So when we talk about value-based care, which is the ultimate concept of ET3, what is the value of, let's start with data, right? I mean, this is the world that I traffic in. So to the degree that there's a show of hands out there of folks in this industry who utilize things like EPCRs, like other analytic programs and so on and so forth, what is the value of the data that you collect? Is it zero? How about less than zero? Is it possible that you actually pay more for the software that you use to capture data than the value that you realize out of it? I would imagine there are going to be some bobbing heads on the other end of the call right now, because there are many people who view the documentation that they capture as a necessary evil, right? It's a compliance requirement, not something they necessarily want to do. And I can't even tell you the number of times I hear on a daily, weekly, monthly basis how we wish we could go back to paper. We wish we could go back to scanny forms, right? So I would also submit, and I now get to say this on record, that ePCRs are the second most hated technology in the world. The most hated would be the electronic health records, Epic, Cerner, and the like, that hospitals and other parts of the healthcare system have to use, yet have a remarkable mystique to our industry because they're used by other parts of the healthcare system. The number of places that have tried to do ET3 and community paramedicine using an instance of Epic Care Anywhere and ground on the rocks that is the EHR, they're not even hard to find. And the idea of documenting in that system, because that system is what the rest of the healthcare system uses, turns out there's a whole lot of overkill, there's a whole lot of design consideration, and not really great for use outside of an office setting. But, you know, those conversations tend to not get had until too late. I would submit that there is a value to the data that you capture. In fact, CMS a couple years ago defined that value, that of all of the invoices and claims that were submitted to Medicare in 2017, 687.5 million of them were rejected. And a substantial portion of that, in fact, 15% were rejected, and 57.3% of these, so about, call it 7.25% or so, 7.3%, were for insufficient documentation, right? So the data that you were capturing to prove what you did, that how you took care of somebody and deserve to get paid for that, were insufficient. So there's a value placed on that because, again, whether it's medical necessity, none at all. This is actually my favorite one. So people just said, pay me, I'm just not going to tell you why. And so on and so forth. There is a specific value to the data that you capture. But the problem is, this is a proxy, right? The data itself don't mean anything. What you're actually doing is saying, this is the care that we provide. You should pay us for the work that we did. And what Medicare has essentially done is said, for approximately 57.3% of the portion that we rejected for a variety of reasons, you actually delivered no value. You delivered no value. We're not going to pay you. You haven't proved anything that you did to the point where we're going to pay you. If that sounds insulting, it should. It's incredibly offensive, but it's also something that can be addressed. So the fact that it reflects on this question, what is the value of the practice that you do? What is the value that this industry delivers? If we can't answer that definitively by being able to say, here is what we do, and here is how people benefit from it, and here is how the benefit exceeds the cost, and therefore, or in fact, the cost being what it is, so you should pay us so that the cost doesn't exceed the benefit and we can continue to keep our lights on. These are real scenarios that ET3 is kind of trying to get to, because as mobile medicine, fire providers, community paramedic teams all say we want to be a part of the healthcare system. So the healthcare system is basically saying, okay, well, if you want to be a part of this ecosystem, tell us what you're doing, right? Show of hands if you've seen Training Day. Here's my homage to a movie that's a bit harsh, but also kind of brings some reality, right? I mean, it's not what you know, it's what you can prove. Seems to be a motif in this business when it comes to data. The problem is this is utilized in our industry as a, right? There is a reason why ePCRs, for example, are hated, and EHRs as well, right? How many of you have heard the phrase, if you didn't write it down, you didn't do it, right? I heard a couple days ago, the head of Lyft said the same thing. She said, in healthcare, it's a common knowledge that if you didn't write it, you didn't do it. But that's not true, right? So the idea that what you document ends up being used as something that gets you in trouble for either with protocol or with legal or whatever is something that makes doing the documentation a punishment. But what ET3 is trying to do is to basically turn the model on its head and say you are providing care, You are providing care that delivers value. Help us measure that value for you, right? So instead of looking at this as a negative, what if we looked at the data as a positive, as demonstration of the value that you provided? And then we have to get into the question of, are we capturing the right information in order to be able to do that? Is ET3, the way it's structured, going to get to the point where we can say this is the value that we provided? So let's talk about what value is, right? What is something worth? I say all the time, like, look, I'm not a medic. I think everybody on this call probably knows that. I'm not a medic. I can't tell you, with the exception of certain aspects of neurology, I can't tell you how to take care of the patient in a way that will hold up anywhere. I can't tell you how to stick a tube down somebody's throat, but I'm very well qualified to tell you what that's worth, right? So what is something worth? And I don't think you need an MBA to answer that question. I think what you need to, if you think about whether it's a car, whether it's a medical procedure, whether it's a computer, whether it's a software system, what something is worth is what the market is willing to pay for it. And this is a serious problem for our industry, because the way that our industry is compensated, and again, that is the acronym, right? The Congress of Mobile Medical Professionals. It was no accident that one of our first objectives as a group was to move the conversation from reimbursement, which is bad, to compensation, which is good. And for everybody who's attending today for the first time, this is something I am particularly passionate about. I think it is insane that we use the phrase reimbursement, because at the end of the day, when you take care of a patient and you use bags of saline and you use aspirin or atropine, or you use an EKG monitor, why are you asking somebody to pay you back for what you did? Like, that's not the point, right? The point is you saved somebody's life. You brought them back to life. You ripped them out of a car. You picked them up off the ground. You should be getting compensated for your work, not reimbursed for your expenses. Reimbursement has a meaning, right? And that meaning says pay us back. And in mobile medicine, you actually get reimbursed in an even worse way, because you get quote unquote reimbursed by the mile. So you're basically a taxi ride, right? And that's a problem, because what you're doing is incredibly specialized. What you're doing is incredibly valuable. The question is, are you proving it to anybody? And that's where I think this whole conversation starts and ends with respect to ET3, because this is your invitation, right? ET3 is an invitation by the federal government of the United States to say, prove the value, and we will pay you for value. We will not pay you anymore by the mile. And so the question, and it's a harsh one, is mobile medicine worth X number of dollars per mile? The answer is yes, until you bring evidence to the contrary. And that is exactly what these models can do. So my passion and argument in favor of community paramedicine and ET3 and mobile integrated health, and whatever else we want to call it, is that they represent the transition of this industry to a model that goes away, recognizes that your value needs to be accounted for and compensated in a matter respective of what you do, not based on the mile, because that doesn't necessarily matter. And therefore, it is incumbent on you, is incumbent on this industry to prove what you did. And I will, and this may be the one statement that ruffles the most feathers, and I hope it does, and I hope we take on with it and have a conversation about it. I have been asserting for at least a couple years that community paramedicine, ET3, et cetera, are not clinical programs; they are data programs. And people look at me and they say, well, of course you say that, you're a data guy. And my answer is that may well be, but that's not the point. The point is that mobile medical professionals, whether you're rolling in hot code 3, whether you're showing up for a community paramedicine visit and a wellness check, you do whatever you need to do to take care of the patient. That is what you do. I know that there are some people on this call. I talked with one of them yesterday. Tom Beers, I think you're on the call, at least I saw you log in a few minutes ago, who is adamant about the fact that the focus needs to be on the patient care. It should not be on the money. And that's true. It's altruistic. It is mission driven. It's incredibly admirable. At the same time, good deeds don't power ambulances, right? They don't power fire vehicles. Those trucks don't run. Even QRVs don't run on coffee and smiles, right? So at the end of the day, the question is, again, you will do what you need to do to take care of the patient, but do you know what they need before you arrive, right? That is a data question. Do you know what they are going to need to get better without being transported and handed off to somebody else who's going to then take it from there and perhaps restart care, which of course becomes a huge source of expense in our industry. Medical transportation is a huge expense, but you know what's even bigger than that? The restart of care when they arrive at the emergency department, and everything that came before gets thrown out the window because you get 30 to 45 to 60 seconds of quote unquote quiet time. And I realized you couldn't see my air quotes on that. So quiet time to explain to the ED team what it is that you did during your triage, transport, initial care, all of the context around that patient. And that 45 to 60 seconds, then they say, well, I don't remember any of that anyway. About 50% of that or so gets lost officially. Anecdotally, about 80% of it gets lost anyway, and they restart. And so this model solves that challenge by saying, but you've done things before we got here. Why aren't we accounting for them? And in fact, they may be enough that you don't even need to come to the emergency department. We still have to ask some questions about that, but that's your opportunity here. So now let's get into some of the weeds on this, right? I have been a long time and staunch advocate, also a thorn in their side, I'm sure, for NEMSIS, the National EMS Information System. The fact is that for reasons that go beyond today, but I'm happy to discuss, NEMSIS version 3 in particular is a critical step toward interoperability with the rest of the healthcare system. And as much as they may rue my emails when I something in and basically say, hey, you need to do this or that, or don't forget about this or that. The fact is NEMSIS is a critical step, and they are doing an amazing job at what they are doing to affect interoperability. But they are not necessarily the ones calling the shots. There's a lot of stakeholders that determine what it is that could get captured in these data sets. And when it comes to ET3, this is it. What you're seeing on screen is all of the data, 100% of it, that are on the NEMSIS website right now as ET3 related data for this program. There's a little bit more I'm going to show you in a minute, because inside these are some various sections. But incident patient disposition, type of destination, and alternative disposition. So do these indicate value to you? Do you see anywhere on this list? Or how about on this more detailed list? Because this is all of them. This is everything. For all of the work that goes into ET3, and Rob, you mentioned that there's going to be a call after this, and Isaac as well, with the ET3 open forum. I hope this comes up in conversation. I have submitted this question now several times to CMS, and they still haven't answered it. So let that be what it is. For all of the work and all of the talk about how we're going to do value-based care, there is nothing on this list that is not logistical in nature, right? Where did we take you? What place did we take you? Did we take you someplace other than a hospital? That's it. So that's apparently what ET3, after all of this work, that's what it's come down to, is did we take you to somewhere else? Not did we make you better? Not what did we do to save you, et cetera, et cetera, et cetera. And the question that I find myself asking is, do the folks creating this even understand that there are ways of measuring value? And I know they do, because they do that with the rest of the healthcare system. So I wanted to ask this group, and this is sort of the last section of my talk here. How do you measure the impact on health in our industry? And the answer is risk, right? So if I can show that I am reducing the risk that you pose to the healthcare system, right? And when I say that sort of haphazardly because there is no healthcare system in the country, right? Duncan can talk about a healthcare system in Australia. Rob can talk about a healthcare system in the UK. Folks in Canada can talk about a healthcare system. In the United States, we have to talk about systems. We do not have a healthcare system in the United States. And that may be a source of stress for some people, but there was a very lively conversation on social media earlier this week about how we should adopt models from other countries in terms of mobile medicine and our role in the healthcare system, but we don't have one. Right, so that is a challenge in that if you look to a place that has a nationalized healthcare system and you try to adopt its practices here, you're going to fall on the rocks of reality, right? We could take the effort of redesigning our healthcare systems and turning them into one. Bernie Sanders didn't win the nomination. So that's a reality that we're not going to be able to do, possibly while I'm still, upright and breathing. But nevertheless, if we wanted to have that conversation, we can. There are not enough people in our industry who understand what actuarial risk is. Actuarial risk is defined as follows. In short, there's a little bit longer investor discussion, but it's essentially how fast are you going to die and how much are you going to cost on the way down? That's what actuarial risk is, right? So if you can show that you can increase life expectancy, which means you are paying into the system, you are paying insurance premiums, you are paying taxes that support CMS, et cetera, et cetera, et cetera, and you are reducing the cost to care for you, you are reducing the losses due to payouts associated with your healthcare over time, then your risk goes down. That's it. That's what our actuarial risk is. And if it turns out that I can show that a COPD patient, a congestive heart failure patient, a substance use disorder patient is coming off the sauce, right? They've gone from smoking 6 packs a day to smoking 2 packs a day, and they are no longer burning their eyebrows because they're taking the CPAP off to puff the cigarette. I swear I could not believe the first time somebody pointed that out to me, and I could believe it less when I actually saw a friend of mine, unfortunately who passed not long ago, doing just that. He was on an oxygen tank with cancer and COPD, and he walked outside to smoke a cigarette. So there is an extraordinary amount of risk associated with that person. And if you can get the number of cigarettes down over the time, you can modify the risk associated with having to pay for that person's care over the long term. And you can model this across a variety of different criteria. But I ask you, the points that have been discussed as the focus of CP type programs, things like readmission avoidance, is that in fact a driver of risk reduction? Does that actually prove that you are doing anything to make the patient better? In fact, I've got a whole other set of presentations we can go into another time about this, but let me submit to you that maybe the patient needed to come back to the ED. Maybe there are reasons for that. And it turns out there is almost no correlation between readmission avoidance and as a practice in clinical medicine, or of which mobile medicine, of course, is one I would define there, and cost reduction. There are significant mathematical errors and misconceptions around the nature of the readmission penalty. Again, go a little bit beyond here, but readmission avoidance does not correlate with risk reduction. And as far as cost savings, who is the lowest cost patient? Right, the lowest cost patient is the one that doesn't engage. So as soon as you are engaging them in a community paramedicine, mobile integrated health, ET3 type program, you are already engaging them. They are already more expensive than if they are sitting at home dying alone. And it may be harsh to say that, but the fact is, when you're talking about the economics of this, the lowest cost patients are the ones you don't take care of. And the one who is in fact, this again, the data show that things like severe, high smoker, severe smokers, severe folks with alcoholism, et cetera, who don't engage the healthcare system because they don't want to get nagged to stop smoking and stop drinking and stop so on and so forth. They are the cheapest patients in the system. So as soon as you start taking care of them, the whole thing becomes more expensive. That's a paradox, and it's one that we need to deal with. But there are ways of reducing risk and proving the impact economically, such as the reduction in harmful habits like consumption of cigarettes, tobacco, illicit drugs, making sure that people have better and more food, et cetera, ensuring that they adhere to their medications. For example, if you have a patient, how many of you have patients that are frequent users of EMS that have bags of pills, right? And making sure that they are compliant not only with 20% of them, but with 80% of them. You can prove that your engagement has increased their adherence, increased their alignment with the medical regimen that they've been prescribed. Money rains down on your head because you can prove that these patients are going to a lower risk environment. And somebody makes money based on that, right? If they are lower risk, there's less cost and they live longer, you deserve a piece of that. That's what the shared savings model was about. That's where the accountable care model came from. And that's ultimately where community paramedicine sort of got kicked off. But these data are not being captured. Similarly, with food insecurity and social determinants of health, a whole category of focus right now on basic everything from adverse child experiences to whether or not your home is clean. And in fact, it turns out EMS World Magazine covered the PEAT score, which is the Physical Environment Assessment Tool, back in 2004. You guys can see that it's a little small down here. 2004, right? And yet, how many people have even heard of the PEAT score or incorporated it into the data that they're capturing for their program? Sorry, there we go. So I encourage you, by the way, to go read that article. It's fascinating. And the fifth one is loneliness, right? And this one is getting talked about a lot now, especially in the context of COVID, because being in quarantine does really unfortunate things to people's mental health. And especially when you put money in their hands and they've got pain, but they're afraid to go to the doctor, we all know that the number of overdose morbidity, the amount of overdose morbidity and number of mortalities has skyrocketed. It's not necessarily in the data yet. There are some communities that are talking about how once the healthcare system kind of reopens in their region, there's going to be a stench, an unfortunate stench of all the people who have not come out of their homes and died in their chairs, right? The upside to all of this is that each of the values here can be priced, right? And I know that sounds harsh, but again, whether you're talking about a nonprofit or a for-profit, you're still talking about the ability to do work and make impact on people's lives and get paid accordingly, because that's a proxy for value. And the fact is, we can price each of these, but we're not even capturing data on them. There's nothing on these in the NEMSIS data set today or the ET3 one, and that's a serious problem. So can we calculate, for example, how much a reduction in tobacco is worth? How about a reduction in fall risk? Almost every CP program that I've encountered has some fall mitigation program, fall avoidance program, whatever you want to call it. But how many people have actually said, this is what it's worth, this is what you should pay me for helping to do that? Because even if there is no profit, right? Even if you're a government agency, municipal, Tom, there's your nod once again. See, I paid attention to our conversation. Nevertheless, it allows you to do it more, right? Because there's always this question of how do we do this for our community when we don't have a budget that we can change, right? Because budgets are set and maybe years in advance. But if we can get people to pay us for the work that we can do, that we can afford to do it more, right? We can afford to have someone who focuses on this or on EMS in general or on mobile medicine writ large. And we have the resources to do more, including send people into people's homes to be their friend. Because this is one of the most direct correlations between cost reduction, however you measure that. And by the way, I think this is tragic that we're still talking about this in 2020, but it's a reality of healthcare as it's grown around the world. The London School of Economics, which is the alma mater of Josh Parrish, EMS chief for the Milwaukee Fire Department, and another nod to my podcast. If you haven't heard him talk about these things, you should listen to it on the GEMS website. He is a remarkable individual. They found that the cost of $6,000 per person just for people being lonely. But if you help them stop being lonely, if you make a phone call and be someone's friend and talk to them about the grandkids that they can't see, like my parents right now in Los Angeles, who can't see their grandkids because my father's immunocompromised due to a transplant, so he hasn't left his home since March. You save 1 pound, 3 pounds sterling, this was in Britain, for every 1 pound invested in actually preventing. And so I would encourage you to read the study. Here's the study from 2017, making the economic case for investing in actions to prevent or tackle loneliness, right? That is mobile medicine. That is community paramedicine. It is where ET3 could go. And again, I hope you'll dig into some of the additional questions that I've talked a bit long here, but hopefully some relevant ideas to some of you. But there are more questions, some really important ones that we need answered with respect to ET3. And it was supposed to start several months ago. So people are a little late in getting these questions answered, and they're still not yet answered. But it has to do with things like telemedicine, right? Are the encounters that you have by telemedicine considered PHI? Do you have to store them for like HIPAA data? How about if you have to share data with an HIE, because CMS and NEMSIS talked pretty offhandedly at a recent call about sharing data with an HIE, but they didn't necessarily address, in fact, they didn't address whether HIEs can even consume your data. And what happens if they can't? And finally, the legal bit. Again, if you go to a patient's home and let's say you have a conversation with this fellow and he says he's lonely, and so you have that phone call, you take care of him, he feels happier, and a couple hours later he dies. Whose responsibility was it to do something else? Who's liable for the fact that he declined? The fact that a medical director said you can leave them there because they don't need to be transported might protect you from going to jail, but it won't necessarily protect you from that patient's family suing you for malfeasance. So these are real big questions that are not yet answered, and I encourage you to read those and a couple others in that white paper that's on the GEMS website. So with that, thank you very much for letting me talk a bit about this. I hope some of the topics are of interest. I want to turn it over to the chat and to anyone who has any questions. And again, thank you guys for all that you do. I am just here trying to make your lives a bit easier and a bit safer. But we are certainly on the right track, and the rest of the healthcare system seems to be recognizing it. Thank you, guys.
All right, thank you, Jonathan. just switch over to the chat real quick. We got about 15 minutes or so for some discussion, and I'm just going to go in order. Anthony, you're first. Go ahead, sir. Tony, your microphone is still muted.
So as we look at our customers, and a lot of people don't like to use the term customers, but especially the last two slides Jonathan shown, how do we find these people that need our help? And I subject you, it's much bigger than waiting for 911 calls and being reactive, or some hospital telling us to follow up on readmission. As you know, a lot of you, I'm a big fan of Dr. Patch Adams and his work, and I subject you for us to find those potential customers, these people that really could use our help and really show that we add value, that we need to engage in the community, and we actually need to get out in the community and get involved with different groups so we can actually start finding out who these people are. It's kind of like the fire department knocking on doors and putting in smoke detectors. They don't know who has them and who doesn't and who needs them. And I like to discuss, and I know a lot of people want to talk on the other on the technical end, which is important, but how do we actually go find and engage these people that we're missing by getting out into the community, developing that process to be active and engaged in the community.
And then one second, guys, if you're dialed in on via phone, please,
followed by the pound sign. Art Grou, G-R-O-U-X.
Art.
Please state your organization.
I think that gave it away.
Hey, whoever's the host, can you mute him manually?
Oh, let me see if I can do that. That was pretty funny.
I just muted myself.
That was a smoking gun, man.
Yeah,
Love it.
Yeah, Tony, I agree with that. The fire department, used to focus on putting out fires, but especially in my area, I'm not sure how it is other places, but it seems like their job is probably 75 or 80% public outreach and fire education now. So like educating the public on preventing the fires to begin with. And EMS, at least in my experience, has long since fallen to the wayside when it comes to public education, health and wellness programs, medication compliance, different things like that. Just reaching out. It's like nobody ever calls 911 for an ambulance until they actually have an emergency. So I think for us to move ourselves purposefully into that realm is something that we're going to have to kind of take the bull by the horns and make it happen, and not sit back and wait for other folks to tell us to do that.
Let me I have answers to, or at least ideas about an answer to your question there, Tony, but I actually would like to call on some folks, if you don't mind, because I think there are people who have perspectives on this and some different ones that I'd love to engage. Helen, are you still here? And Duncan, are you still here? I see you both on the list.
Yeah, I'm still here.
Perfect. If we can go with first Helen, then Duncan, and I think because Helen's been doing CP programs in North Carolina for a long time, and Duncan doing it in Australia. I think those are two really interesting perspectives as to sort of how you get those folks engaged and how they're engaging now and finding them. Would you guys mind speaking to your experiences?
Getting people engaged is a challenge. If you're talking about the patient, yeah.
How are you finding them? What's your method by which folks are popping up on your radar screen? And Duncan, again, in your system, given that you have a very different structure of EMS in general, I'd love to hear how that's different. Maybe we can learn from some of that.
Well, we have very specific program areas. One is opioid follow-ups, and so every morning I get a report that shows me how many overdoses we had the previous day, and we look at those overdoses to see which ones are opioid, and then we try to get in touch with them. We seem to have more success with them than we do with one of our newest programs, because we're still trying to figure out how to approach them, and I'll talk about that in a minute. But once we get in contact with our opioid overdose patients, then we actually work with a peer navigator to make connection, give them harm reduction supplies, get them connected with services for recovery, et cetera, et cetera. So that's how we do that, and it seems to be fairly successful. But the other thing that we just recently started was a fall prevention program, as you mentioned. My ears perked up as you said that. But we are seeing challenges. Again, we get a report every morning that shows me how many people fell, how bad gravity was the previous day. And then I go through those reports for anyone who's age 60 and older. But we're not having as much success with reaching out to them. Well, not with reaching out, but with getting them to agree to allow us to come in and talk to them about the reason they fell, what we can do to get them connected with resources, PT, OT, whatever it is that they need. We're not having as much success with those. Still trying to figure out the best way of doing that.
Awesome. I have a follow-up for you in a minute, but let's turn to Duncan. Duncan, how are you guys doing in Australia as far as engaging folks in a CP context?
So
and actually, you know what? Let me wrap my other question in with that, because I think because you do have a nationalized health system, do you have the ability to do a proactive engagement as opposed to what Helen talks about, for example, looking at the reports of what's happened the day before or whatever? Do you have the ability to utilize that nationalized data set to be able to say, here are people who are high risk, let's get to them before they become a problem? Okay.
Depending which state, because we're state driven, we don't have little private ambulance services, individual ambulance services like you guys do in the States. So effectively we've got about 8 main services. So yeah, we each state's different with what they look at and what their sort of primary goals, so to speak, are in that particular space. We're also moving into the paramedic practitioner perspective as well. So we're connected with GP clinics and other aspects like that. So depending, like I'll speak for one of the main states I work in at the moment. We've got our CAD system set up that identifies these low acuity calls, because let's face it, I would say probably 80 to 90% of the calls we would go to wouldn't even require lights and sirens. It's not emergency based or low acuity care. So our CP style program officers, who are generally postgraduate trained, they'll go out, they'll see these people, they'll identify whether they can treat and stay on scene and then leave them, or treat and take them to an alternate destination, or if it is beyond the capability of either of those two, a lights and sirens acuity unit will come and transport them away. And then they'll just move on to their next case. Now the inherent risk, when you sort of go back to risk, is quite high. Probably our community or low acuity type paramedics have the biggest risk, because there's always that high probability that we leave someone behind, they will die. So our risk is massive. So, I mean, we're fairly similar to the UK paramedic practitioner mode. However, at the end of the day, if you're talking about world leaders, I'm sorry, the UK are the absolute world leaders in paramedic practitioner models. I mean, they smash it out of the park. I mean, they're already administering ABs, for goodness sake. So, I mean, we haven't quite got that far yet with our program. But yeah, I mean, if you're looking at world leaders, the UK's paramedic practitioner model is just off the chart. But again, we're talking about 2 very different healthcare systems in the way we operate. And I can sort of see ET3 going in sort of the direction that some of these other locations are doing. Look, it is to some extent very much data driven. But for Australia and the UK, what I can speak of is that we've gone through a significant evolutional change over the past sort of 15 to 20 years. We don't look at ourselves as technicians. To sit at the big table with other medical professionals like doctors and nurses and other allied health personnel, we've gone through the clinician approach. So we're university-based entry to practice, and for our advanced development, we've gone into that postgraduate practice. So I think there's that aspect within your system over there that needs to change or develop in that direction as well. Because I mean, I've seen plenty of reports where you guys are like if you ask the average person over there what's the value of paramedics or EMTs and things like that, and they just refer them as just transport drivers. And I mean, that devalues what you guys do over there tremendously. And again, it took us a long time for that kind of mentality to be taken out. And it was a slow change, but we sort of now put on that process where we're sort of going forward in that space. But as far as what we look at as our key things, look, realistically, we're all fully developed with EPCRs over here. They play a key part of the healthcare system record as well in Australia. And we've got these various metrics like falls and other risk assessments and things like that, which we include as part of our details. And we include that as what we've got success in certain areas. And we're even looking at expanding things as well, like the geriatric response unit. We're looking at incorporating our community paramedics when they're too busy to go out and see and treat in that section as well. So we're trialing that in a particular area in Queensland at the moment. So yeah, it's a very different system, but the grounds of what you're discussing here now is something that we've been playing with for about 10 years. However, realistically, I think the UK provides you the best model as to how well this really works.
Thank you,
That's
Duncan.
my opinion.
Yeah, give us a lot to think about there. One of the things that's
it's early in the morning, so I talk a lot.
I get that way after a couple of cups of coffee. One of the things that really stood out there were some of the things that we talked about when we were first starting out with the CoMMP group, and that was the educational and licensure requirements. But like what you were just talking about with your program, having the postgraduate education for these paramedic practitioners, to me that just seems like it puts some pretty strenuous implications on our licensure and credentialing programs, as well as our pre-hospital education system here in the U.S. That those are some big things that would need to be beefed up a little bit, or maybe even overhauled in some areas. It
doesn't, because if you look at how UK, Australia, New Zealand, and in some aspects Canada have gone about this, is that they've taken what was previously used and they've sort of beefed it up or sexed it up a little bit, so to speak. So when I've written a paramedic degree as well, and I've also done some other programs internationally. And actually the foundational building blocks of the programs I built were built off the EMT and EMTA. And I use them as the foundational building blocks of the degree. If you're looking at a degree program, I think people look at it and they get scared, so to speak. Realistically, if we take your EMT, your EMTA, your paramedic, I won't look at CP or CCP because those type of programs are sort of more your postgrad direction. But if we just look at the EMT, EMTA, and EMTP program, realistically, there's half to 3/4 of your degree already in place. All you have to do to make that an actual degree, and I know most of your programs are invested through colleges anyhow, is you just have to add the university coursework that needs to be sucked into it. So if I gave a real simplistic version, look at a public health degree, look at a nursing degree, and you could incorporate the bits that are missing that are required to make up a degree around the key aspects of the paramedicine. You wouldn't need to reinvent your paramedicine education because that's already there. It's just filling in those little voids and gaps. Very, very straightforward and easy to do. And that's what the other countries like Australia and the UK and New Zealand have done, is they maintain their core paramedic training and then just added the bits that were missing. And as the system evolves, you can make it a bit better. And the postgraduate programs, like your critical care, your flight paramedics, and your CPs, well, again, they just looked at what was already there, and then they incorporated sort of looked at what other postgraduate medicine and nursing were doing, and then they just contextualized it to suit pre-hospital care. So it's not as it looks daunting, but it's actually not that daunting. But you are right. Once that sort of gets integrated, then you've got to look at pay scales and other aspects like that. But if I want to put it back on the US, look at what the nurses did. Look at how they evolved to where they are today. They had to start somewhere. So they give you a good model to see, well, what did they do to get to where they are now? And that sort of gives you a bit of a benchmark on the trials and tribulations you may have to face. I'm not saying paramedics and nurses are the same thing. I'm just saying it just gives you a good model to sort of look at where do we need to go to sort of go to that level and sit at the big table.
Right. That's a good point. With that, we're gonna it is 1 o'clock by my clock, so technically it's time to stop, but Jonathan's willing to stay on, and I've got some time too. So if anybody needs to jump off, feel free. This will be a recording that you can get catch up on later. But if you still want to stick around, please do. Jonathan's going to be looking through some questions that came from Alan and Jacob and Chris. And if I could turn the floor over to Daniel just for a second to elaborate on some of the things that you were wanting to say.
Yeah, hi, my name is Daniel Fry. I've started running a community health program here in my city in 2012, and we've got a pretty robust program right now. With full disclosure, I also, like Jonathan, am a data guy. I now have co-founded a EPCR company, but I'm kind of a little on the other end. I'm more of the patient care. You know, the one thing we talked about is, you know, data first, patient care, you know, it drives that. I think patient care needs to come, you know, is first and foremost. We've got a few patients that would go to the hospitals a lot. And if the data would show it, they were going to the hospital for chest pain, they were getting treated for chest pain, one for diabetes. And if we were to treat them based on what that information showed, that's what we'd be treating them on. And come to find out, it's more things around the house. One is a lady was going for chest pain because she knew she can get food at the hospital. So if we treated it by chest pain, we wouldn't be treating her, and she would just continue to be going to the hospital. And so it's kind of a little of both. The question I was going to answer though was when somebody had talked about how are we finding our patients, or how are we getting people into the program and drawing people into the program. What we found is if they don't know the programs out there, there's no way to bring them in. And fire departments, private EMS, and hospitals know the programs are out there. What we have done is reached out to churches. There's a lot of pastors that see sick people in the home. Those people may never go to the hospital. They may just rely on that pastor or somebody in their church. And as long as that pastor asks, you know, hey, would you mind if these guys came by? Then we can go and educate them on what our program does. And a lot of them go ahead and will sign up. Another way to do it is we'll go to Meals on Wheels, a lot of our community outreach programs, and introduce them to the program. And as long as they know the programs out there, it grows, and we are able to reach those people that eventually end up becoming our hug or our high utilizers through the program. We're able to slow them down or prolong them needing to go to the, you know, care facilities. So.
Yeah, I think actually I'll dovetail on that because I think there's an interesting, just real briefly, there's an interesting sort of one-word undercurrent to that, which is marketing. It's kind of a weird thing because I know there are people on this call who get sensitive about the idea of considering mobile medicine to be a business. And that's okay. That's a separate conversation, right? But the question of sort of assuming that people know it's out there or that by word of mouth things will get out there is not necessarily always the case, right? There's a lot of noise in the market right now. And there's a lot of people doing this type of work. So Alan asked a great question. Sort of how do you find out that the patient who needs food, you know, if they keep calling for chest pain? And I think it actually gets to sort of the same question. You ask, right? You talk about it. Yeah. That's where everybody in the department, everybody in the city or the you know, the service becomes kind of an advocate for this level of engagement, right? I mean, it's a matter of, I think that the question that's come up several times, Duncan hit this on the head. Are you reacting as technicians, right? Like I see this, I do this. Or are you engaging as clinicians? Tell me what your pain is, right? Tell me where it hurts. And I think that level, in fact, that's something I know Helen and I in our conversations other times have had that conversation very deeply about the psychology behind the clinical engagement, right? And are you getting deeply enough into the patient's needs that you get to that level? I think, Daniel, you hit on the head, right? So much of that is about letting people know that there is a service in your community that will do that for even the neediest patients. To the whole idea of letting them know they're not alone, that word will spread, but someone has to sort of say, well, look, just because we're a fire department or EMS agency, don't assume you know everything that we can do.
Exactly. And this is not marketing you need to go spend money on. Right. You're going to these nonprofits, letting them know they're the ones that are in touch with these people, whether they're going to the hospital or not. And it's a good way to,
I had an interesting conversation with a very well-known CP program about 2 weeks ago on this very subject. And we were talking about Alcoholics Anonymous type programs, right? And how or halfway houses, right? And the idea that those organizations, and here's where things come to the possibility even of making money or generating revenue, however you want to call it, around these programs, is those organizations need these patients too, right? They get paid to take care of them, right? If you're a halfway house or an anonymous program or a clinic, you get paid for everyone who comes in your door. So they want to be able to engage with you as someone who's helping bring them the people that they need to take care of. It ends up, I've found it ends up being a much friendlier conversation than I think a lot of people realize. The territorialism tends to go out the door much faster than people think. Once you get beyond sort of the top level advocate association level, down at the ground, folks are working side by side. So.
Absolutely, and your point exactly. A lot of our patients come from home healthcare agencies because they are on a set time on how long they can see them, and we follow up. We start integrating in the care program. So we've already got care programs, everything done with them. And then when they drop off that program, they just continue on with ours until they're in no need whatsoever.
There's one other bit to this. Again, I think talking about revenue models for community paramedicine and ET3 is probably a little more than we have time to do right now, but I'll just throw this out to the group as something maybe we talk about another time. And that's, again, this perceived dichotomy or opposition between, for example, home health and community paramedicine type programs. And one of the things that I've found is very interesting is sort of once you look at the types of patients that end up in mobile medical run programs tend to be both high risk and a lot more focused on things like mental health and substance abuse and so on and so forth, right? If you are a home health patient, a home health service that wants to send out personnel to check on your bedpan and your medications, make sure your oxygen tank is full and so on, you don't necessarily want to go someplace where you could get stabbed, right? I mean, you don't necessarily want to go someplace where the person could end up having a psychotic break on you. But this industry does that every day, right? So the idea of like rolling in hot to someplace where someone is having a very, they're in crisis was actually the phrase that this organization used. That's something you do every day. So the idea that you can actually provide a service to home health or provide a service to a community nursing type program where they give you the patients you are better equipped to handle than they are, actually offsets risk for them, right? We go back to that earlier topic about the fact of risk being a huge part of this conversation, right? That if you can take some risk off of them by saying, well, we're better equipped to do this, we're going to be your partner instead of being your competitor. Now, all of a sudden, you guys are benefiting from each other, and it turns out those niches are pretty substantial. And again, can certainly power the economics of your program going forward. Now you're not even talking about readmission avoidance or even lower cost of care. You're talking about doing a job where you wouldn't necessarily want to do the plumbing, right? You hire a specialist. You wouldn't want to go do the extraction out of the grain silo. You hire a specialist, right? That's what we're talking about. So in this case, you're hiring a specialist to take care of something that is more than the home health team may be equipped to handle safely.
Another huge niche is hospice. We do a lot with hospice. Absolutely. Because when hospice only has so many nurse practitioners, nurses for so many patients. So when those patients, they're trained to call when they're in severe pain or can't breathe. Well, that's exactly what we deal with. So instead of going to 911 and getting transported to hospital, getting taken off hospice companies will reach out, put us on as the second call. We go take care of that patient, leave them at home. They don't get taken off hospice, and hospice is willing to pay substantially for help through community health programs.
Jonathan, Clint, I know you got a few other comments from some other people in there too.
Back to you, Clint.
Yeah, Daniel, that hospice, that's fantastic. That's a great benefit to the patient and their family too, by not being booted off hospice and have to go through the junk of getting back on. That's a great way to reach out. Let's switch gears and switch over to Chris Sandoval if he's still on. He was asking a little bit about the CMS waivers and flexibilities. Let's see if anybody can help him out with that. Chris,
yeah, just a quick question to the group. One, we're not probably going to be an ET3 site, but I'm wondering if we can create a pseudo ET3 by utilizing CMS flexibilities and waivers for the public health emergency. Is anybody doing this? Is this even possible? I'm curious.
So I don't have, I'll tell you, I don't know if, I don't have an answer for that, but I would add, if Crystal Yamans, you still on here? I see she's
Yes,
called
I'm
in.
on here.
So I think Crystal would be somebody who at least, whether now or later, could provide some guidance. Crystal and her community are actually building kind of their own ET3 program, ET3-like program. If you don't mind my calling out on that, Crystal. So I figured maybe you have some wisdom to add on this, or you and Chris could connect as well on how you guys are doing it locally.
Yeah, we don't, we have a really small community. We have like 15,000 people in our community, and we have 0 alternate destinations. So we're really looking to focus on develop for our community paramedicine type of program, and more of a telehealth part of it. And of course the treatment transport, which we've already been kind of doing that anyway. But so we're kind of trying to tailor everything to us. We just got a grant through the Rural Health Office for our state. I think there were 6 of them awarded to different states in the county or in the country. So we just got that grant that's helping us.
So we're also in an urban environment, and we're getting a lot of pressure to engage other specialties, social workers, and most notably taking some of the burden off our law enforcement because of some civil unrest, to try to bring some of these other practitioners into the fold and maybe get reimbursed for it. Is anyone engaging like a social worker or occupational therapy, physical therapy in a CP program?
Hey, Chris, this is Dave Moffett with Phoenix Fire. So and kind of going back a few paragraphs ago, we don't have the problem of going out and finding customers. They find us, probably like you, right? We're a big municipal fire department. And so in times past, we were a part of the EPIC TBI study and the Sarver cardiac arrest study. And while those things didn't necessarily focus on any kind of reimbursement or any kind of monetized strategy going forward, because ET3 won't work for us. We set up our ambulance geography. So I guess I need to go back and say that the Phoenix Fire Department, we run our own ambulances staffed by firefighters, and they're all ALS. And they're really, really busy. And we have a 2-tiered response, right? We've got our own dispatch system that qualifies calls, and if they're codes, childbirth, that kind of thing, then the ambulance goes on them.
We use DMD and all that 2-tier system as well.
Yeah. And so what that means is that we don't dispatch ambulances on every call. We triage them for calls that systematically don't seem like that they require an ambulance. And then ET3 comes along, and on the surface, that seems like a really great deal and a really great opportunity, but it is an ambulance-based system, right? So the very calls we would not be dispatching the ambulances on are the calls that ET3 demands that you send them on in order to be reimbursed. So as we were looking at it, what we had determined, and again, we're in the infant stages of an EPCR program and everything, so we wouldn't even have been eligible for ET3. But along the lines of the EPIC and Sarver studies that we were in the past, is that we've been having conversations with the behavioral health REBA within our region, with the Medicare, Medicaid payers, to create our own native system that works for our environment, that doesn't make us have to redesign how we deploy ambulances and all that kind of stuff. The next step for that, of course, would be having a mature EPCR process. And then we lucked onto a guy out of Texas that, and this goes back to a comment that Jonathon brought up a few paragraphs ago, which was that I heard him mention that looking at hospital readmissions as doesn't necessarily align with great patient outcomes, right? The two, they're not necessarily correlative, right? But this guy that we're talking with does have correlative data on what good outcomes for these people are. And so I would like it, and who knows if we'll actually go with him, sign a contract, whatever that kind of stuff would be. But I think that we could be industry leaders in this and turn around and show payer sources of the value that we're providing, because we would have hard data that's not necessarily aligned with an HIE or anything else. It would be native to our system there. It's a lot of work, where I'd like to see it go is that we would be able to convince this guy to also look at the same kind of metrics and measuring that he's doing right now and apply it to behavioral health calls.
Amen.
I think that's fantastic. That's awesome.
And just a quick, this is exactly what we're all trying to do with CoMMP and in the regular meeting. So once we get past here, this conversation is not done.
And
Chris
Sandoval,
Duncan from Australia, mate. It's I'd put a little thing. Have a look at Niagara EMS. Chris Sandoval, that is. Yeah, they've sort of done what you were sort of talking. Alternate and what David was mentioning too. They've also got that alternate triage 911 call in as well. So that if they don't require an ambulance based on how they triage the calls, they send out those other groups. But yeah, just it's on their website. They've got a couple of YouTubes and things like that. It's quite amazing. And I know they're Canada, but the concept's the same with what you're sort of talking about. And from a whole, they're based in Ontario, obviously their province, and they're sort of like the shining light, and they're leading the way in that province quite well. So that what they're doing might help you quite well.
Awesome. Appreciate it.
And another thing to talk about in there, Phoenix Fire has had a 25-year, what we would call a crisis response program, where we had a van with trained behavioral health counselors to go out on some of our calls. And unfortunately, that thing has been the first program to be cut when we get into hard times with budget or other things. And I've learned in my 6 years of doing project and program management now that anytime that your program is purely funded by grants or overtime or volunteers, you've probably not got a good program, right? It's at some point it's going to be doomed when the next axe comes to chop. But we, and to your point, Chris, law enforcement has been carrying some of the water on this, and that probably like a lot of major urban areas, we've had some rioting and protests. In 2018, the officer-involved shootings had doubled over what the previous 5 years had been. And ASU, Arizona State University, and the National Police Foundation came in and did a study. And point number 9 within that study is that they needed to do better integration within the behavioral health system. And we had determined, because I had already been engaged in pilots with our REBA behavioral health system, and they just are not built for 911 response, right? They're built for layperson, civilian direct calls for service. And again, this is almost the triaging the ambulance conversation, in that their agenda is to stabilize the person within the community. And if they can't do that, then they'll dispatch one of their behavioral health vans to go, but that is to also stabilize that person in the community. And really only as a last resort do they take those people and put them in some kind of behavioral health urgent care or institution or something. But that didn't meet the needs of the 911 system, not for the police officers and not for the firefighters. When we called, we'd really done the bulk of the triaging and saying that this person, what we don't want to do is take them to the emergency room where they don't get any kind of definitive care. They're going to get a referral out. We would like to cut the emergency room part of this event out of here and get them direct to care. And we ran into conflict with the existing native system that was there with that. And so what we determined, and it just happened last month, was that we went to city council and got our, what we call our CR, or crisis response system, dispatched through the fire department. We grew it out to where it's a resource, not just for the fire department, but actually for all city departments, but in particular grew it toward the police department, to where we're going to eventually, it's $11 million to do this, but we're going to have one per fire department battalion. And with the goal being is once we've grown it out to that size and can start having a big bulk data set, is next we're going to go shop it to the payers to see about, I'm going to use the word reimbursement, and it's going to make Jonathan's skin crawl, but some kind of monetization.
I accept your gaff. You have a pass.
That's great feedback. I really do appreciate it. Thank you.
My pleasure.
Thank you, Dave. That was awesome. Clint, back to you.
Yeah. Does anybody else have any questions or any further discussion they'd like to engage in?
Up there further, who was it? Somebody had a question.
I'm looking for.
Way up there. Wow.
If you had a question that you put in the chat function that was not addressed, please.
I think Jacob, you had mentioned earlier, Jacob's still here. He had one earlier.
I think he's gone. He's gone.
All right, we'll cycle back.
Hey, Clint, I just want to put this up to, and I don't know how we do this. We should talk about after each one of these, since there's so much discussion, how we can continue the discussion somewhere in social media or Google group or something, so we can get to the essence of it. But for the continuing discussion, we have a place to take it so it doesn't die when we're done with the recording.
Yeah, I'm gonna just go ahead and throw this out. We'll put the recording out through our normal channels, and there'll be kind of a summary, talking points or whatnot, document that we put together that can go up on social media as well. But yeah, I'll get with Jonathan and Tony, and we'll get something on social media following this to kind of create a place where we can continue the dialogue for those who wish to do so. There'll also be a short survey that'll be coming out to all the participants to ask for input on how we can modify the structure and what people liked and what they didn't like. But before we wrap up, let's go over to Chris Wooten. Chris, you still there?
I'm still here, thank you. I just have a question for, if you're assessing the value of the MIH program or the value that we're providing to a patient off of actuarial value, how do you assess the entire program then? Is it a sum value of an individual risk index for the total number of patients you've identified in your community, or are there other metrics you can use to determine both the health of the community and the value of your MIH program?
Is that a question for me?
Yes, please.
Okay. So just to summarize, you're basically looking at, do you doing it in aggregate or individual by patient? Is that what you're saying?
Correct.
So the answer is actually both. So, or either, I should say. The actual answer to that is essentially going to come down to the type of compensation structures that you're seeking for that. So, for example, just if you see on screen here, I think I'm sharing again, right? The way that you stratify risk is really everything to the answer to your question. So if you are looking at individuals who, for example, are, again, sucking down too many cigarettes, and so you have a COPD problem in your community, right? That is probably best addressed on an individual basis, because you can't get the community as a whole to stop smoking, right? On the other hand, and I think this came up in in fact, in Chris Sandoval and Dave's conversation just a minute ago, there are certain types of program structures that are more community oriented. For example, I remember the first time I learned that the highest incidence of diabetes in the United States is in Harlem, period, right? So not just in New York, but specifically in Harlem. And a lot of that has to do with, to the point that someone was asking earlier about food, and we were talking about whether the actual issue that you're calling for is the reason that's actually keeping you sick. If you have diabetes, or if you have diabetes that's borderline, but it's out of control because you don't have better food options, as a community, right, you can incentivize fresh food to be brought into the community, right? You can work, again, to Chris and Dave's point, at the city level, at the city council level, for example, to modify zoning, for example, or allow people, let's say you don't have, structural supermarkets coming in, maybe you incentivize food carts to come in where people are selling fresh fruit, right? So I think, Chris, your question is really well placed as sort of which way you stratify and then account for the risk, but it really depends on what your problem is. So that's where the whole idea of doing that community risk assessment and tying it into the various participants, I don't want to say payers, because people tend to think that's insurance, but it's really who the stakeholders are, right? If your stakeholders are looking to address community level problems like the lack of food, so if you have food deserts, then that's something that there are public health, for example, may very well have a stake in that outcome, and there are other organizations, others who can help bring those solutions to bear. Whereas if you have more of an individual problem, if you have a mental health issue on the one, a crisis in your community, on the one hand, that may be dealt with on an individual level. Like, again, like Dave said, that, patients sort of coming to them. On the other hand, there's a lot of controversy, and for good reason, around things like safe injection sites and so on, right? Where if you are introducing community level solutions to solve individual substance abuse problems, are those mismatched, or are they exactly what you need? And so I think it really depends on sort of what the nature of that is. That's where the data is going to help you understand what the problems are. But I tend to think that the challenge, and this is one question that never got addressed today that I think actually goes directly to what you're pointing out here, and we should talk about it later, is the use of data proactively, right? So everything that we're talking about is reactive by nature. But to the degree that you can dig into data to see where your problems will arise and be able to beat it to the punch, I think what the question that you're asking goes directly to that. Because if you can see from other sources of information that your community may have more than one type of problem, you may need to take more than one type of solution, right? And so it's not necessarily a matter of either or, individual versus communal, but you may have some of one that's causing some of the other, and so on and so forth. Does that sort of answer your question?
Yes, it does. My experience comes from the military. We had something that was similar to that, where we had to both. Yep. One of the metrics was, they called it PMISI slides, where you're looking at an entire community.
Yep.
And a correlating metric was, how many bad guys got killed that week. And typically, as one of those numbers was higher, that usually meant that one area was worse. But both could be determined, hey, you're doing a good job. And I think you're kind of hitting on that. Is it's going to require more than one solution, and you're going to have to be very specific about what metrics are being applied to which population. So thank you.
Yeah, absolutely. Just one more thing to tack onto that. So I mentioned earlier that I talked to Josh Parrish, Chief Parrish from Milwaukee Fire, in a recent conversation, largely about education and engagement. And he's a London School of Economic grad. I mean, this is a very, very geeky, in the weeds guy, who's also an EMS chief in a fire department. And that was actually one of the really interesting threads of our conversation, just to your point there, of how you, when in sociology and economics, when people define society, right, there is this sense that society kind of emerges and it's its own thing, right? It's like a corporation. It kind of exists unto itself. But the truth is that's an error, right? Anybody intuitively can tell you that a society is made up of its parts, right? So just like you're describing in a military context, when you go into these communities and, what happened in that community individually affected the community. I look at it in terms of disaster response, right? The high level regional disaster response is the sum of all the people and things that were impacted in the disaster. So I think it really is, and Wooten, I think you would find a lot of success in looking at those programs as a 1-2 punch, where as you solve the individual problems, you will solve some of the community problems, but some of those community problems are best addressed as such, because if you try to feed each person individually, as an example, food security, that can be done in one fell swoop and solve a lot of people's challenges. But recognizing that there are also other things that require an individual touch, because some people are going to be too scared to come out of their homes. They're never going to participate in the supermarket that you just brought in. So it really is both directions. And I think that's a very insightful observation. So thank you for bringing that up.
Jonathon and Clint, both, something else we should be doing is somewhere in our comp world is taking these people with the best practices, agencies with best practices, and putting them somewhere as a clearinghouse that people can learn. I know we all talked about breaking down silos way back before comp was comp, and it was just fire EMS vision. And I think, I haven't figured out how we do that, and collectively we will, but we can put these best practices at clearinghouse. So once people get done having these discussions on social media, there's actual tools and information they can use.
Well, that's one of the things we'll talk about, I think, in the business meeting, because one of the things was about the wiki and the sharing of knowledge. Go ahead, Clint, sorry.
Yeah, I think that exactly was the purpose of this format that we started trying today. was to have that end product that other people could use to help guide them.
Let's call on Jacob if we could. He came back in. And Ruben just volunteered to share some insight too.
Hi, sorry, I almost had to run off and do like actual work. So my question is, as far as the metrics that you're using to validate these initiatives with your stakeholders, used actuarial risk, and that's something I'm not as familiar with. In terms of most of the economics literature that I've read, it's validated in QALYs. And so are you familiar enough with both to compare and contrast and speak to which one is of more value in getting buy-in with stakeholders?
Define QALYs. I saw the acronym before, but I'm not familiar with the particular acronym.
Quality adjusted life years. So basically, that's
actually an inverse. Yeah, I am. They're inverses of one another. So they're directly related. Basically, the question. So in an actuarial, this is are you seeing my slide here with the curves?
Yeah.
Right.
Yes.
So
yep.
So the actuarial table is essentially raw data, right? So when you look at this, is just an output of the actuarial table. This is from a particular study, but there are lots and lots of these. Right? There are whole associations and societies of actuaries that are worth looking into some of their publications. They're really in the weeds. They're kind of fascinating as to how detailed these things can get. So the quality adjusted life years essentially is the inverse of this, right? This is looking at how long you would live, what your cost, your contribution margin essentially to your local healthcare ecosystem would be, depending on how those stakeholders are. And then essentially what the quality adjusted life year concept applies a kind of an ethics to that, right? So basically it's not just asking what happens if you live longer and cost less. It's essentially asking, should you do that? It ties directly into some really important modes that are aspects of care. Who mentioned hospice earlier? I forget, it was someone mentioned hospice, but it gets into, I think it was Duncan, right? So it gets into questions of like pulsed, for example, so end of life orders, the right to die movement. All of that sort of picks up where this leaves off, because this is all about the cost structure and the expense and revenue relationship. The inverse of this is the question again of, should you live longer? Is it a good idea to keep living if all you're doing is going to the doctor more? Obviously, we all know people who have gotten up in years and like every other day they're going to the doctor, and the question becomes, is that worth living? Are you still able to go to the movies and do other things that you ultimately would want to do? And therefore, is it worth this calculation? Does that make sense? So they are directly related. Again, one is raw economics. The other is sort of recognizing that economics is at some level a social science, not just a numerical science, and sort of asking the question of, is it worth it beyond the numbers? So I don't know if that answers your question, but that is the relationship between them. It's a very hard conversation to have in certain contexts, because again, quality adjusted life years it's a bit of a fuzzy concept, right? I mean, for you, when you're 90 years old and you really want to go golfing, right? And for the next person, they want to be able to stay at home and read a book. How that would make them happy for the rest of their golden years. What you need to spend on them in order to get that is completely different, right? One person, if they're at home and they're mobile and they're awake and they've got oxygen, they're fine. The other person, you have to make sure that they're able to walk around a golf course for an extended period of time. So it becomes a very hard calculation to do because it's got a subjective element to it. But that's how economics work, right? I mean, economics does involve some level of the question of, should you do something just because you can? Actuaries don't look at that. And that's actually one reason why insurance conversations tend to be really tough, right? Just because you can give somebody a new liver or a new heart doesn't mean you should. When you look at what, the fact that they're going to live 6 more months as opposed to the next person who's going to live 6 more years, well, to that person's family, those 6 months are everything, right? But you can never get to conclusions that way. when you only have one liver or one heart and you have to choose who to give it to. So they kind of take this dispassionate approach, which can be really discomforting politically. It's very hard ethically, but it is nevertheless kind of a cold numerical truth that allows you to make certain decisions. Does that answer the question, Jacob? But I think it's a fascinating evaluation tool to look at the two. And you and I can talk separately about how that ties into some of your research and whatnot.
Right. And
awesome. Thank you.
So, go ahead.
And Chris Wooten, I think, yeah, your point's right there. If you want to speak a little more to that, because I do think it's a really interesting, it's kind of where all this needs to go, right? Once we've sort of gotten some framework of how to have the conversation with everyone understanding one another's language, then you get into the question of what should we do, and now you're at kind of a more evolved practice. You want to speak to the ROSC component?
Chris, are you still there?
Sorry.
Sorry, I had a toddler. I had to move to the other room. Thank you for your patience.
No problem.
Just that MCRIT about a year ago did a pretty good series where they were looking at just because we're having increased ROSC values across the country, it doesn't really correlate to 30-day discharge. It doesn't increase to an increase in cerebral function or quality of life. And so now they were speaking specifically to ICU physicians and resuscitationists of you need to begin looking at real metrics of should certain resuscitations take place, because are you adding a value or quality by delivering that care? And it seemed to be very consistent with the point that you were making.
Yeah, I appreciate it. Like I said, I think to me, and I don't know, I was on mute for part of that. I think if you have that research, by the way, and you can bring it to bear, that would be great to be able to see and be able to have this conversation. I think when we first started talking in this forum as CoMMP about where we were going to go as a group, I think that was a large part of it. And Clint or Tony or Moffitt, feel free to or Alan, tell me, folks who've been there the whole time, tell me if I'm wrong on this, but I don't think I am. I mean, it was really this idea that value is kind of everything that we're talking about, right? We can talk about it in terms of compensation, but it's a lot about mission and making the practice better. And a lot of that is being able to be informed and obviously to build those relationships across even our own industry disciplines, being able to bring in insights from ICU, for example, where people might be surprised to realize just how similar the dilemmas are that they deal with. And so now we're starting to, again, take that place at healthcare's table. There's so much that can happen when people can come together and say, I understand what you're going through, right? The empathy bit also leads to the ability to talk across the aisle. So if you feel inclined to share some of that in the various channels that we have, I think it would probably advance our conversation a lot.
So Jonathan, Tony, and right on with what we're talking about, because I think we have to find the baseline of accepted value to start with, and we're already trying to do that. Back in the days, every cardiac arrest was a worthwhile save, and at some point we realized that it wasn't. But you hit on the empathy, and again, Compassionomics and Patch Adams is big. There's value in compassion. There's healthcare value and savings, as well as patient improvement and outcomes. So I think we have the ability through both medicine and just our interpersonal dynamics to make a great dent and impression in the quality of healthcare in communities. And we just haven't knotted all that together. We're taking bits and pieces, but slowly we're starting to create that continuum care, as said earlier, that holistic collaboration of different types of therapies. Because even compassion is a therapy that we're going to be able to show value to, that will benefit people both on a subjective emotional end and a quantitative cost value end.
If no one else has any other questions, I would submit that that's kind of the perfect ending note. That was here, Tony. Anyone else have any other burning questions, thoughts?
I will posit this. If there are other things that came out of this roundtable discussion that you'd like to further discuss or get more information on, we'll be soliciting for future topics on the Facebook page. Please go in there and feel free to drop it in there as a potential topic. Also, I think I saw here, Anthony, correct me if I'm wrong, that we're going to try to get the conversation up and running on the Slack channel. Is that correct?
Every channel we have, hopefully we'll get Slack to actually have activity.
Okay. All right.
So we'll use Facebook, we'll use LinkedIn, and we'll use Slack. And if we figure it out, we'll actually use our Google group too.
All right. Well, with that being said, just keep an eye out on the Facebook page, Slack channel, Google groups, or however you're following along. And let's keep the conversation going. And all this information can kind of be incorporated into the notes from today's roundtable. And be looking for a survey that's going to come out soon electronically, and it will be anonymous, just to get some feedback for us on how you liked or what you didn't like about today's structure. And our next meeting will be November 5th. That's 2 weeks from today, Thursday at 12 Eastern time. And it will be a business meeting for CoMMP. It will not be a roundtable discussion.